For this fireside chat, I'm going to start with a few slides to tell you how Kyverna is progressing on the journey to pioneer CAR-T therapy for autoimmune disease treatment. We started this journey about 4.5 years ago, and we have come a long way, and I'm pleased to share with you what our future is starting to look like. We have a very unique CAR construct. We believe that it is well suited for the treatment of autoimmune disease. It was a construct that was developed by the NIH. It's sort of the sister construct to the construct that is Yescarta, but it has a fully human binding region, and it was engineered to reduce lower levels of cytokines upon activation. And it had a very good safety profile and good efficacy in a head-to-head study between Yescarta and our construct. But there was no real compelling reason to change the construct for Yescarta. And we believed that those engineering elements were a benefit to treating autoimmune disease patients who really should not mount an immune response to their therapy. That would be a bad thing, yeah? We've treated over 100 patients with KYV-101, and we are the potential to be first in class with a clear path to BLA for our first indication, which I'll cover with you in the next couple of slides. Our modality and how we benefit patients, we provide a single dose. It's not a repeat dose. It has a mechanism of action that deeply penetrates the tissues and clears the B cells at their source very effectively. It's very firmly on target specificity, targeting the CD19 expressed surface antigen on B cells. And we are able to provide disease-free remission, and patients remain off of their suppressive immunotherapies for long periods of time. And when you look at the alternative modalities, they don't have the same profile as ours. I'm going to cover 2 indications in this presentation. SPS, stiff person syndrome, is our lead indication. We have finished enrolling and dosing our registrational study in SPS, and we are unblinding the data, and we are compiling it, and we'll report out top-line data soon, and then we will be on our way to our first BLA. This patient that you see here is a patient that was treated on a compassionate use pathway in Germany. It's known as individuelle Heilversuch, and she was treated 2 years ago. Her last follow-up was at month 23, and she remains off immunosuppressive drugs, and you'll see her data along with a second patient who was also treated via the individuelle Heilversuch pathway. The other patient, Denise, you're going to see in a video at the end of this presentation. She was our first patient treated with MG, which is our second indication. She had her last follow-up at month 24, but we treated her in June 2 years ago, so she's 30 months and counting, also completely off of immunosuppressive therapies and continuing to receive benefit. This is just to tell you where we are on our journey. We completed our phase 2 enrollment in stiff person syndrome, which was a registrational phase 2 study. We completed that in mid-2025. As I said, the last patient last visit was held a couple weeks ago, so we are compiling the top-line data and plan to release it early in the year and to file in the first half of next year. Myasthenia gravis, we have a confirmed registrational path with the regulators, and we have started enrollment in our registrational study. We reported out positive phase 2 interim data at AANEM just a couple of weeks ago, and I'm going to share those data with you here as well. And then we have additional data that we've released that have been generated through institution-initiated studies in multiple sclerosis and rheumatoid arthritis, giving further evidence that this is a very good treatment broadly for autoimmune disease indications where B cells play a big role in the pathogenicity of the product. We are also working on a second-generation autologous T-cell manufacturing platform called KYV102, and we are filing the IND this year. So starting with stiff person syndrome, how many of you have heard of stiff person syndrome? Okay, that's good. Who's the most famous person with stiff person syndrome? Celine Dion. Yes, she's not one of our patients, sadly. Stiff person syndrome is a very, very rare orphan indication that has no approved therapies for its treatment. We think it's underdiagnosed. It is a series of autoantibodies that disrupt your neuropathways and shut down the suppressive signals that come from your central nervous system to your muscles. And so your muscles will spasm and contract, either triggered by light or sound or just naturally. It results in muscle rigidity, which can lead to falls, fractures, and fear. And so a big part of the comorbidity, if you will, is these psychiatric syndromes of fear and depression and anxiety, because you never know when these are going to hit. And as a progressive disease, you can end up being completely immobilized and stiff. 80% of patients lose mobility, needing walking aid assistance or a wheelchair. Freezing attacks and sudden falls result in ER visits and can lead to permanent disability and even death. Here is the data from our 2 Individualheilversuch patients. Let me see if I can get this is right, yeah. Patient 1 is the Kelly green dots. Patient 2 are the forest green dots. Patient 1 has been followed beyond 23 months, but her last visit wasn't month 23. And patient 2 has followed beyond 9 months, but her last recorded visit was 9 months. This graph here is the timed 25-foot walk. This is a valid instrument that is used for neurological diseases like MS and MG, where mobility is severely limited, and so we are using it for SPS as well. A timed 25-foot walk, if you have normal mobility, can probably do that in a matter of a few seconds. You can see that these 2 patients started off with a timed 25-foot walk in excess of 20 seconds. But quickly after administration came down to half that, 10 seconds, and has continued to plateau or even slightly decrease. Now we're pleased with this data. What we don't know is if it can go down further. Is that due to regeneration that needs to happen? Or is it really confidence? Because these patients have been so long with this disease that they are still very hesitant. They're afraid they're going to fall. This is a more objective slide. These are the reduction of the autoantibody titers. Again, you can see very high with patient 1, not quite so high with patient 2, but rapidly before 2 months, decreasing down dramatically, and in one case to baseline. And patient 1 has also returned to baseline. The last thing I want to say on this slide is what were their therapies that they were on. So before KYV101 treatment, patient 1 had 6 supportive therapies that they were on. And after KYV101, none. And still, 2 years out, none. And patient 2 was on 8 supportive immunotherapies, and after treatment, none, and still none. And so we haven't seen the data on our registrational study. As I said, we're unblinding it now and we're compiling the data. But this is indicative of what we believe we will see. Moving on to myasthenia gravis, this is our second indication, also a neuroimmunologic indication, not quite as rare as SPS, but still very high unmet medical need. There are approved therapies for myasthenia gravis, so I'll show you a little bit about how KYV-101 data stack up against some of the other therapies available. In general, what we say is that the other therapies don't really bring curative potential. They do bring some relief, but you have to have chronic readministration of the therapies, and you continue to rely on background immunosuppressants. And our goal is to get rid of all of that. So what is myasthenia gravis? Here, again, the autoantibodies disrupt the signal to the nerve cells of muscles, and that's all muscles. So your lungs, your heart, your limbs, and you can be very debilitated. You can be intubated. You cannot move. You cannot talk, and it's quite life impacting, and is also can lead to mortality. Here is a list of some of the other types of therapies that are approved in this space and what some of their limitations are. KYV-101 does, as I said before, deeply penetrate the tissues and get rid of the B cells at the source. And so we believe it also will have good benefit in these patients. So we have 4 targets that we want to deliver for these patients. First, we want to give them unprecedented disease control with a safe product profile. We want to have more patients reaching minimal symptom expression, otherwise known as MSE. You can't detect through symptoms that they have a disease. And to remove the background immunosuppressants all in a single dose treatment. And this is our interim phase 2 data. 6 patients. 3 of them reached the primary endpoint of 24 weeks, and 3 are on the journey. 5 have passed 12 weeks, and 1 is still early. We have 2 instruments. The MG-ADL is one instrument of measuring disease, and the other is QMG score. And clinically meaningful improvement for MG-ADL is a greater than 2-point reduction in the score. That's where this green line is. And for QMG, clinically meaningful improvement is greater than 3-point reduction, which is where this green line is, okay? So, MG-ADL, at 2 weeks, we had a mean decrease of 7.8 points on the MG-ADL score, well below the clinically meaningful improvement. And at 24 weeks, we were at -8 on average. And at 36 weeks, 2 patients have gone beyond 36 weeks, and they're going down even further. For QMG, similarly, at week 2, we had an average of 7.8 reduction in the QMG score. And at week 24, this is with 3 patients, so not all 6, we have the average of -7.7, still well below the clinically meaningful benefit. And you can see the 2 that have gone to 36 weeks have gone much lower still. So we believe that this is a really good indication that our registrational study in MG is going to be successful. So we believe we've really set up our phase 3 study in a good way. The 2 indicators, the MG-ADL score and the QMG score, are the right scores to be measuring. We had 100% responders in our phase 2 study, and at week 24, 2 of the 3 patients that reached week 24 had achieved the MSE level as well. 100% of the patients are free of suppressive drugs, And the administration of KYV-101 was consistently well tolerated and had a very manageable safety profile. Our CAR toxicities are not severe at all. They're grade 1, sometimes grade 2. So how does the data stack up against the competition? Well, here it is. We have Fc inhibitors such as Vyvgart. We have complement inhibitors such as Autoimmune. We have CD19 antibodies. We have BCMA mRNA CAR. And then we have KYV-101. Our primary endpoint was 6 months. That's fairly standard. For MG-ADL reduction, we had a reduction, as I said, at 24 weeks of 8 points. And you see the others were around 4. QMG reduction, at 24 weeks, we had a mean of 7.7 point reduction. Vyvgart reports 6.2, and all of the others are much less than that. All of these trials had 70%-ish, 60 to 80% responders. We had 100% in our phase 2 study. Our phase 3 study is much bigger, so we'll see how that is powered. And then achievement of MSE, 40% for Vyvgart, 43% for competent inhibitors, not reported for the anti-CD19 antibody, 33% for the other CAR. And we had 2 of 3, so 67% at or before the primary endpoint. So it stacks up well. So we believe that reduction in MG-ADL and QMG exceed the magnitude of effect of all of the other competition. And with deep, sustained treatment effect, with no retreatment, and all of these others have retreatment, we are able to continue to have patients have minimum symptom expression and stay off of their immunosuppressive drugs. So in summary, KYV-101 has the potential to deliver durable disease-free drug remission with a single dose. Kyverna is positioned to be first in class in our neuroimmunology strategy. We have a strong cash position, and we continue to advance future pipeline opportunities, both with KYV-102 and in other indications. And I'm going to end here with a video of our first patient, Denise. She had MG. She was treated through the Individualheilversuch pathway. She is out well past 2 years. It was June that she passed 2 years. And this video is in German, but don't worry, we have English subtitles.
Die ersten Symptome hatte ich beim Laufen, haben zunehmend die Beine nachgelassen, dass sie einfach so eingesackt sind. Und dann fing es an, dass es auf gerader Strecke auch so war. Die Ärzte haben ja immer zu mir gesagt, ich bilde mir das ein, da wäre nichts. Und ich denke mir, ich bilde mir das doch nicht ein, ich fall doch hin. Hieß es irgendwann, ja, ich verliere zwischenzeitlich das Bewusstsein. Und das war auch nicht der Fall. Ich konnte denen ja genau beschreiben, was passiert. Ich musste gepflegt werden, gewaschen, gefüttert und so weiter. Ich habe dann immer mehr Probleme beim Sprechen und Schlucken gekriegt, sodass ich dann nur noch Flüssignahrung. Mein Job ist, mich um meine Kinder zu kümmern. Konnte ich nicht aufgrund meiner Krankheit, weil es teilweise so schlimm war, dass ich mich selbst nicht verpflegen konnte. Dann nach 2 Jahren hatten wir dann die Diagnose durch einen Bluttest. Wir haben ja hier ganz viele Therapien versucht. Wir haben ja die Thymusdrüse entfernt, dann haben wir verschiedene Therapien probiert und so weiter. Und alles hat immer nur so zeitweise funktioniert und danach kam wieder der Einbruch.
In Germany, we have a law, the so-called individuelle Heilversuche. This allows the physician to apply therapeutic approaches that are not approved in those patients where the regular and approved drugs have been exhausted or there is nothing available. I was intrigued by the option to apply CAR-T cell therapy. Denise is one of these cases. We have been trying to stabilize her disease for the past 3 years. She needed ICU care several times with ventilation and intubation despite an efficient immune therapy.
Dann hat der Chefarzt von der Therapie dieser Zelltherapie gehört. Da habe ich gesagt, klar habe ich Interesse dran. Ich möchte alles, was mich voranbringt, was mir hilft, dass ich dann auch wieder für meine Kinder da sein kann und so weiter. Und als es dann soweit war, dass die Infusion dann kam und da war ich die Ruhe selbst. Aber bis dahin war ich total nervös. Aber dann in dem Moment war alles gut. Ich wusste, ich kriege das jetzt die Infusion und gut, kein Problem mehr. Und ja, je mehr Tage vergingen, je besser ging es mir. Und dann war ich oben, war total begeistert und denke mir, wow, ich bin die Treppe hochgelaufen, wie das denn? Konnte ich ewig nicht und hat funktioniert. Und jetzt will ich hier den Fahrstuhl nutzen und mich sieht jemand dann immer so, nein, wir können aber die Treppe nutzen.
That was really impressive. Thank you so much for sharing. And I think, we talked about that before, right? Really hearing the patient's voice and what it really means for their life is just so much more than data. So thank you so much for providing this to us.
Yeah, well, our patients really inspire us every day. And Denise's story is particularly heartbreaking as she was a mother of 4, and you could see she's young, and she was bedridden, intubated. They thought she was going to die. So this is really fantastic outcome.
Absolutely, yes. Thank you so much. So yeah, you already shared a lot of insights. One of the things I would like to get us started with is we already know CAR-T from the oncology space, what it does in leukemia, what we need to do, what we should not do, what challenges we have, and everything. Now, for autoimmune disease, you are really one of the pioneers. What can you share that you have learned so far? What is the same? What is different? How should we approach it in comparison to leukemia?
Yeah, that's a good question. And what I always say is, if you come from an oncology background, and you have developed CAR-T therapies for the treatment of oncology diseases, everything you think you know, think again. Because in autoimmune disease, it's completely different. The starting material is not as problematic as the starting material for oncology is. You don't need the same level of dose because you're not dealing with malignant levels of B cells. Your CAR toxicities are not as high because, again, you're not dealing with that target burden. So we've learned quite a bit about the application of CAR-T therapies for autoimmune disease, and we're continuing to look at where we can push the envelope. Part of KYV-102 is going to look at other things, different starting material, even a lower dose. Can we get rid of lymphodepletion? How do we approach outpatient? So we really want to open up the opportunities for more patients in community hospitals like were discussed last night.
That's amazing.
Yeah.
Maybe just leveraging on the topic of dosing, can you share a little bit about how you approached the dosing component, again, being one of the first ones who do that in a new setup?
Yeah, so Kyverna's approach has always been to build on what's already been demonstrated to work. So we licensed the sister construct to Yescarta for the proven efficacy and safety in the oncology setting, and knowing that the changes to it would be beneficial to patients with autoimmune disease. We looked at the dose ranges that have been prescribed for CAR therapy in oncology, and we picked a dose on the low end of that range and one lower than that, just so we could make sure that if CAR toxicities were going to be high, we could deal with it. And luckily, we hit the right target. I mean, we haven't had to dose escalate from the target we administered. Both dose levels were safe and effective, but we chose the higher one because we believe it has more durable response, whether it's because it gets deeper into the tissues and more effectively clears the B cells that aren't accessible in the periphery. We're not really sure, but the evidence shows that the higher dose does give more durable response.
And can you share side effects, if any, that you observed with specifically maybe higher doses?
Yeah, so the CAR therapies are known for their CAR toxicities, mostly CRS and ICANS. Our instances of ICANS have been very rare and very low grade. Our instances of CRS are constant. We believe it's a signal of active drug, but they're grade 1, grade 2, sort of like you get after you get your COVID shot. So easily manageable. They occur at a relatively known window of time. And so we make sure that we're watching patients for that window of time, but they do not reemerge later in the therapy. There isn't re-expansion because we aren't dealing with the malignant levels of B cells. Our bigger side effects, we believe, have to do with the lymphodepletion chemotherapy. So we're working on making that gentler.
Got it. That makes perfect sense. Now, the underlying concept that you are working with is the immune reset approach. Can you share a little bit about what that means? And is that, in the first idea, when you hear it, it sounds like being unspecific, and if maybe it would require a more specific approach, but the data, of course, are very convincing. Can you share why you think this is the best approach?
Yeah, so what we wondered was, and Georg Schett's data, which was published in 2022, shows this as well. In autoimmune disease, after you clear the B cells, you'll see the T cell expansion, you'll see the B cells clear, you'll see the T cells reduce in number, and then you see the B cells reemerge. In oncology, that's a bad signal. They're usually still carrying the malignant signature. For the cells that reemerge in autoimmune disease, they appear to be naive. They are undifferentiated and more immature in their development, and they are not expressing autoantibodies. So we think it's a good thing because your humoral immunity is not compromised long term. And we don't really know what triggers the production of the autoantibodies, if it's environmental, if it's genetic, or what. But at least for the patients that you've seen data for the period we've followed them, they are not producing autoantibodies. Now, we have also said, if they start to generate autoantibodies again, we could potentially retreat. But because the B cells come back as naive and they are not developing these autoantibody signatures, and because there are other cell populations within your immune system that are also affected by the CAR treatment, and in a healthy way, we consider that immune reset.
That makes perfect sense. And I mean, right now you really focus on very, very sick patients, but of course we know autoimmune diseases are everywhere, right? There are just so many people affected by that. Do you think potentially if we continue on the same way and think a few years ahead, that this could really become a broader approach that could be used to treat that?
I think so. We have a number of challenges. The first is to educate the rheumatologists and neurologists on what CAR therapy treatment really is and why they shouldn't be afraid of it. The second is we need to get the cost down. The third is we need to make it widely available, and we need to get rid of the parts of the process that, frankly, nobody wants to sign up for. I mean, autoimmune patients don't generally want to sign up for 3 rounds of lymphodepleting chemotherapy before they get their treatment. They would probably maybe want to try something else first. They probably don't understand what apheresis is, nor do they want to know why they should go through that. And then they don't really want to wait a month to 6 weeks to get treated, even though they're not mortally ill like cancer patients, and they won't die probably in the wait period. They still are very sick, and they deserve to be able to be on their road to healing. So what we're trying to do is eliminate those roadblocks through education, through better process development, through clinical studies that allow us to open this up to outpatient and really make this a more meaningful offering, a more competitive, meaningful offering. And I would say also, when you look at the video like of Denise, there's this whole quality of life component. I mean, she's in her 30s, early 40s, and she can lead a normal life.
Yeah.
You know, it's really...
Absolutely. It really makes a difference.
Yeah.
So we also want to open it up for the audience. We have a few more minutes, so if you have a question, please just raise your hand and wait for the microphone. While we wait for that, there was one thing that was very specific in your story, which was that you used this last resort approach. That was a very specific situation with the German law. Can you share insights? Is that something that you would recommend? And what did you learn in the story? So how did that go? How did that come together?
Yeah, so it's a good question, and it's a question that every company would need to evaluate on their own. Individuelle Heilversuch, as you heard, is a pathway in Germany where a physician can treat patients with an unapproved product if they feel that the risk-benefit would really benefit the patient, and if all other options have been exhausted. As a company delivering that product to patients, it is not a clinical trial. There are no enrollment criteria. You can advise on administration and monitoring, etc., but it is not part of a clinical study. It is reviewed by an ethics board, but there is no regulatory pathway, and you cannot have a commercial interest. And so there's risk to the company, and there is risk, of course, to the patient, because if you misjudge whether or not the risk-benefit is there, you can have really bad outcomes. It's not an easy thing to do, and the company needs to decide each case whether or not they believe the risk-benefit is there. And if they say no, there is no appeal process. I would say we learned a lot. We treated 40 patients this way, and we got data across 15 different autoimmune disease indications, and we learned a lot about our dose, about the safety profile, and about how to judge this risk-benefit scenario. But I don't think it's a path I would recommend for everybody. I think you can do it if you and the treating community think it is a good thing to do. But I would probably recommend that you explore institute-initiated trials instead of the IIT or IH. Now that there's evidence that this works, I mean, when we were trying it, there was no evidence that any of this worked. So it was a way to help us get interest in the IITs and in our studies.
That makes perfect sense. All right. Well, thank you so much, Karen, for sharing all of these perspectives. That was really interesting, and sharing the patient videos, first of all.
Yeah.
So thank you for your time.
Thank you. Thank you very much.